So Dr. Hawari is a consultant pathologist here with us in Derby and Burton. She's always a fantastic speaker at the symposium. We're delighted to have her. She has a special interest in gynecology, and she's a core member of our specialist gynae cancer MDT.
Thank you so much for the invitation. Can you see my screen? Yeah,
yes.
and you can hear me well.
Yes.
Okay. Yeah, thank you so much. It's been a pleasure being part of this amazing day, to be honest, and see a lot of people reaching really far beyond our even national audience. And I recognize recently I'm becoming like famous because of this. So it's my pleasure to give you an update on pathology. So many things have happened recently in the world of endometrial cancer and in gynepathology in general, since we had this new update from the World Health Organization with this fantastic publication in 2020, really thick book, nearly double the size of the previous one, that included so many, changes in the classification, including a lot of molecular and a lot of prognostic factors that we are now learning and updating everything, and really made us think again about a lot of the tumors. But endometrial cancer as well show it's a very tremendous change in the last classification. This is a very good kind of journal from the Gynepathology, International Journal of Gynepathology in 2019, that a whole journal dedicated just for endometrial cancer. Fantastic, edited by, of course, Professor McCluggage, who's very well known worldwide. In a couple of weeks, we also have another update from the International Association of Gynepathologists and from the British Association of Gynepathologists, just dedicated for endometrial cancer. The nice guidelines to include microsatellite, routine microsatellite immunostains as a screening for all patients with endometrial cancer was introduced in 2020. Also, that has a huge impact on the service and our ability to actually find those patients and refer them and risk stratify them much better. But of course, as Anna touched on, the ESCO guidelines for the management of patients with endometrial cancer, that was introduced the same year. And we've been following that now for in the last 3 to 4 years. So the prognostic factors, so pathology is very, very important. Like it's going, like how well you're going to treat those patients and how your chance of success totally depending on your pathologist. So, and it's never been like this. Like this is a huge weight on our shoulders to get it right. Because everything is, almost everything is depending on the pathology assessment, starting from the histological type, the grade of the tumor, what's the depth of invasion, what's the vascular invasion, is it extensive or focal, what's the stage of the tumor, and of course the age of diagnosis will play a major role in the prognosis. So a tumor type, so how we think about the tumor types, I think with the tumor types, anything which is not a grade 1, grade 2 endometrioid adenocarcinoma is considered aggressive. So this is easy. So only non-aggressive tumors are grade 1, grade 2 endometrioid adenocarcinoma. All the other types, including the grade 3 endometrioid, serous, clear cell, carcinosarcoma, dedifferentiated, undifferentiated, name it, fall under the aggressive category. So this is, we can simplify that now. Now the grade. The grade, nothing changed in the grade. We still grade 1 and grade 2. The difference only that grade 1 and grade 2 are lumped together as low grade, and grade 3 is the high grade. And it's depending on how much of the tumor showing glandular and how much of it showing solid architecture. 5% is the cut point. Above 50%, you will call it. So it's less than 5% solid component grade 1. Above 50% grade 3. Anything in between grade 2. Myometrial invasion still the same. Nothing changed. Inner and outer. But I will talk about that, about the new FIGO that just Anna mentioned, and there's a difference in this category. Cervical involvement, we assess the cervix is if the tumor extends to the cervical stroma just below the level of the first mucinous endocervical gland, it's a stage 2 tumor, and we'll talk about that. And of course, the very controversial, difficultly extensive lymphovascular invasion, as Anna touched, it's quite hard because there's a lot of inter-observer variability between consultants on to actually assess lymphovascular invasion. It's not easy because there's a lot of mimics, carryovers. But if we have 5 or more blood vessels involved, this is what is considered extensive lymphovascular invasion. And we've been using this 5 blood vessel cut point long before we even have the newest FIGO. So as Anna mentioned, and I know there will be a little bit of repetition, which is, I think, good because we keep emphasizing the same point that we risk stratify the tumors according to so many things, including the tumor grade, the tumor type, what actually is there lymphovascular invasion or not, what's the depth of invasion. And this is all, we categorize them into these different risks. And we've been doing this for years now. And I can assure you, we definitely doing far much better job now than we used to do, like say 5 years ago, into actually trying to target the high risk group and give and treat them and de-escalate the ones that don't need any further treatment. And this is a pie chart that actually I took a picture from the new WHO, talking about the grade 3 endometrioid. Grade 3 endometrioid adenocarcinomas, they're so different with their molecular classification. As Anna mentioned, the 4 different categories, and that actually made us think about those grade 3 endometrioid adenocarcinoma, that they are completely different. Although they share that they are all grade 3, but they have completely different prognosis according to their molecular. Being 12% of them will show Boolean mutation, which don't need any really further management if the tumor is confined to the uterus. I'll come to that later. And 18% of them show the more aggressive B53 mutation, and this is the subgroup that will need chemotherapy and maybe, as we mentioned, HER2 as well, Herceptin. And like the intermediate group, which is the microsatellite deficient and the non-specific molecular profile, these are the intermediate group that share a lot of like the risk is actually halfway between the two. So this has been published long time ago. So we know about this for really so many years now. Sorry, do you want to say anything? Okay, so the Boolean mutation, which is like I've dedicated a whole talk for the molecular last time when we did the talk about cancer. So I'm not going to repeat that again, but it's just to summarize it, it actually has excellent prognosis. That almost all patients are surviving after 5 years with no disease progression. The P53 has the worst prognosis with only 50% of the patients surviving 5 years. And of course, the non-specific molecular profile at the microsatellite deficient group at the intermediate group that is basically in the middle. So this actually been acknowledged, and it's been included in the classification of our and the risk stratification of our patients in our MDT. The only obstacle is the bully, which I'm going to talk to you about this because there's quite a good update on this now. And of course, this has already been touched upon about what are the different treatment available, and I'm sure there will be many talks about that. So what I'm going to do this time, I'm going to just pick the case, and I'm going to show you what actually happened to this patient. It happened to be one of Mr. Abdul's patients, just by chance. I didn't mean Somi to pick on one of your patients, but it was one of yours.
Okay, perfect.
To highlight the excellent work and how beautiful the hysterectomy is. 79-year-old. So I'm just why I picked this patient, because this patient is it's also like to show you how different we do things now, how we used to do them, say 5 years ago or 10 years ago when I started my consultant. Life was so easy back then. Everything was like, okay, that's like one line. Refer, all the patients are treated the same. We didn't have any like risk stratification the way how we do it now, and we do a lot more now. So this is a 79-year-old. Her history, she only had rheumatoid arthritis. She doesn't have really any, like I've looked at her history, she doesn't have really any other, like she's generally well, she doesn't have a lot of chronic diseases. And she just presented with postmenopausal bleeding, and she was referred by her GP to see, of course, gynae oncology and endometrial. Of course, there was an ultrasound done. The endometrium was really thickened. So that biopsy was sent to us by Mr. Abdul as, really, I think this is cancer. Please treat this as urgently. So we have a different, like if you label something urgent, we make our best to at least to report it within a week. It's not really guaranteed. That sample took about 10 days to be reported fully. All pathology departments in the world are under tremendous pressure. There's a lot you have to do more, and the lack of biomedical scientists and the lack of pathologists in most departments make it really challenging to keep. But we try our best to keep up with the tremendous pressure that is now in gynepathology, especially in gynepathology, because we have to do far much more than what we used to do a few years ago. So this is a biopsy. He sent us two, like a quite a nice bulky biopsy. We actually divided it in two blocks because it was quite a lot of tumor, and I like having, like I always say, please, there's no such biopsy say is too big. I don't believe that exists. The more, the merrier. I love to see far much more representation of the tumor. Makes me far much more confident into what actually I'm telling you in the report and my interpretation. So the tumor, it's quite very blue because you have a lot of crowded back-to-back glands. We have areas where it's slightly more solid and it's fused. So overall, I gave it a grade 2 endometrioid adenocarcinoma. And just like a quick reminder of why I called it endometrioid. So for the endometrioid cancer, you don't see significant cytological atypia usually. You see mainly glands back to back with little intervening stroma, and you see a focal squamous differentiation and sometimes a mucinous differentiation. So these are the features which makes us say this is endometrioid. So this is not the end of it. So in the past, like 5 years ago, this sample will take me 1 minute. Say, this is grade 2 endometrioid adenocarcinoma, full stop. And we stop, one line. Not anymore. So this sample, the moment I make a diagnosis of adenocarcinoma, I've requested a panel of immunohistochemistry. That includes P53, microsatellite, 4 of them, ER, PR, and P16. This is the panel we introduced in, like we do here in Derby. And what I do as well, I immediately order Boli. And this is very interesting because we just started doing that from May last year. And I'll come to that later. So that's the P53 immunohistochemistry. It's a nuclear stain. So this was wild type P53. Some cells are picking it up strongly, but many cells are entirely negative. And we have to make sure there is some staining in the stroma in order to make sure that there's an internal control and that actually immunostain has worked. What I did as well, estrogen receptor was strong and diffuse, and that's always a good sign that this is actually, we're not dealing with a very aggressive tumor. Like losing estrogen receptor is quite significant prognostic, and we don't have really now strict guidelines, but we are understanding better and better now estrogen receptor, and the scoring of estrogen receptor in endometrial cancer is definitely coming soon. What I do as well, I do the microsatellites immunostains, all four of them, and we can see all four of them are preserved. So that means it's a normal expression, and this patient, very unlikely for her to have Lynch. So to make sure that the immunostains worked, you have to make sure as well that the stroma has weak staining internally to actually interpret this stain. Now, if the MSH2 and MSH6 are both missing, this is the usual combination in Lynch, then we refer the patient for genetics for Lynch, as a possibility of her having a germline. But if MLH1 methylation only, MLH1 only lost with a combination of BMS2, then before sending her for genetic, we make sure that there is no MLH1 hypermethylation, which is the most common cause of loss of MLH1 in these tumors. Only 5% of patients we expect to have Lynch. One thing before I forget, if you want to treat that patient conservatively, so let's say a young patient who has a low-grade tumor and it's confined to her inner myometrium, or there's no myometrial invasion, if she has any microsatellite abnormality, it's not recommended at all to treat her conservatively. Just before I forget, so it's just an important thing to take into consideration when you are thinking of conservative management for fertility. What I do as well, these two are not really absolutely necessary. P16 and PR. I like PR. I think it does give you like reassurance that it's actually hormonally, that it is positive. I find it's slightly more sensitive than ER, or more predictive of actually response to therapy. P16, you can easily not do P16. I don't think it's the one that I think in the future I think we will stop. But usually you see this patchy positive staining in endometrioid adenocarcinoma, what we call mosaic, like some areas positive, some areas negative. It's helpful in a setting where you think a cervical primary, because P16 will be strong and diffuse if we think the tumor is coming from the cervix. Certainly, if I see very strong P16 staining in this setting, I may start thinking, and especially if ER was negative, I may actually suggest this is a primary cervical. So in the past, my report used to stop here. Imagine half a line. Now we report all this. We say P53 is a wild type. Actually, this one, just ignore that. ER and PR positive, and the microsatellites are preserved. And I send a sample for poly testing. So poly testing so far is done as the next generation sequencing. It doesn't have an immunostain or a rapid molecular test that we can do at the moment in the UK. But this has been commissioned, all the service to the molecular hubs in the UK. Our hub in Derby is East Genomics, which is based in Cambridge. And after long, really, discussion with them, finally they have the capacity to do the work from Derby. So we started sending them samples, and we took an approach in Derby that we sent all endometrial cancers, which proved to be a fantastic thing, because we went against the BAGB guideline of only sending certain tumors, because we thought no way you will be able to actually predict which ones are poly. So we send all. And the recommendation now from FIGO is to test all. So we actually were already doing what's supposed to be done. And we discovered it's actually a lot of work. Cambridge demand a very comprehensive, of course, like the effect of that on our lab is quite big, because they need like a certain number of unstained sections, first and last H&E. They demand that you put the tumor percentage, label the tumor. So it's actually a lot of work for endometrial cancer, because it is a very common cancer. It has a huge effect on the lab and on the pathologist. So this patient, just to continue with what happened to this patient, exactly a week later from this diagnosis being issued, which took about 10 days in our lab, she was discussed in the gynae oncology MDT, and the radiology was reviewed, which basically was, we think it is most likely a FIGO 1B. There was some concern that may be extending to the serosa because it was so close to the serosa. But overall, there was no serosal breach. So a decision was taken that she needs a bilateral salpingo-oophorectomy and a simple hysterectomy, total hysterectomy. And that's what we received. So thank you so much for Shirley. Um, she's our biomedical scientist. So we are so lucky in Derby to have such experienced, amazing biomedical scientists who actually do the cut-up for us. So rarely I touch these samples. So they just leave me just glued to my microscope. They don't want me there. But we train our biomedical scientists to actually do the macroscopic description and sample sample the gynae cancers as well, and they do a fantastic job. Of course, they go through all the training, and we keep on like doing constant education. And I think most of them are attending today's meeting as well. So this is basically the bread and butter of dissection for gynae tumors. Hysterectomies are extremely common samples. So what we do, basically the macro description, you measure how big is the uterus. So it's clearly a very bulky uterus for somebody who's in her 70s, really abnormal uterus. So clearly nothing on the serosal surface, both ovaries were normal. We cannot see like any tumor bulging out or any like abnormality on the from the outside, only that it is big, a big uterus for a 70-year-old. Um, what we do next, and this is really, really important, and I want to touch on that because I have now an audience of gynae oncologists and people who send us all the time those samples. It's very important to send those samples really quickly to pathology because if you leave them in formalin for a while without the sample being bisected, the formalin cannot really penetrate the tissue, and we have a risk of completely losing the tumor and not able to actually interpret anything on histology. So that's what we do. We get the sample to our lab. We bisect it in the middle after put a little bit of ink on the margins. And it looked like that very large bulky tumor. It's actually filling the whole of the cavity and pushing out into the myometrium. So what we do next, we leave it to fix because we cannot really cut it when it's like that, very fresh. So we leave it to fix overnight and we cut it the next day. If the tumor is very, very bulky, then we make more than one incision just to make sure that the formalin is penetrating inside. And we put a bit of tissue to make sure that there's like always formalin going inside the tissue. So that's what it looked like the next day. Then serially sliced along the long axis, and you can lie it like this. So you can see tumor in all of the sections. And you see the difference between, this is the area which was exposed to formalin, the cut surface. You see how it's like completely fixed now, while this area still has a bit of red in it because it's still like far away from the formalin. And this is very, very important. The fixation, optimal fixation in histology, extremely important for molecular and for immunohistochemistry. And we cannot, if the sample is underfixed or overfixed, we will not be able to get results on immunohistochemistry, and it will be extremely difficult to interpret the P53 and the microsatellites. They may not work at all. So what we do next, we sample as well. So we sample of course, both ovaries, fallopian tubes. We do parametrial shave. We sample the lower uterine segment, two sections of the cervix, and of course, we sample the tumor with the adjacent serosa. So let's look closer. So you see how the tumor is so close here. It's very, very close to the serosa, only like a couple of millimeters away. So the next is sample 1 block per centimeter for the tumor, and pick the ones which have the closest serosa. So these the sample. The whole tumor was sampled in about 5 sections because it was about 45 millimeter maximum dimension. And we try to avoid the sections from the cornu because it's very difficult in the cornu to assess myometrial invasion because the myometrium is very thin there. So we try by all means to avoid the cornu sections unless the cornu sections actually show serosal involvement. That's important because that upstage the tumor. So just a closer look to these beautiful sections. Well done. You should have like a nice space around them, keep them really flat, about only 2 millimeter thick. And this is what the H&E would look like at the end. And this is actually, I scanned those slides to show you a very low power from what the histology would look like. Nice full sections. We don't have any holes in them or any with a beautiful serosa on the surface. And to have a closer look, so the tumor is a grade 2, it's invading the myometrium, and we can see here it's actually invading the outer myometrium, and it's only about 1 millimeter from the serosa. So this is, I looked very carefully, I couldn't find any lymphovascular invasion. So where we look for the lymphovascular invasion, you look here at the interface between the tumor and the myometrium. This is where you find the lymphovascular invasion. And I think we are getting better and better in identifying lymphovascular invasion. The only worry, because, well, I'll come to that later, because lymphovascular invasion is a category by itself now, that if I have a very, very strict rule on to call it, for example, only when it is 5 blood vessels, then maybe some departments who have a much more looser rule, as like they may call it when they find, for example, 4 or 3, they may actually overcall a whole category or undercall a category. So this is why the FIGO 2023 has been postponed for a year, because we wanted to make sure we actually understand what extensive LVI means. From my experience, and I've been doing this for so many years, I can tell you the category that is extensive lymphovascular invasion, you can even see it on low power. You don't even have to go and hunt for the blood vessel involvement. And this only will be seen in about 5 to 8% of tumors. So this is really extensive lymphovascular invasion should not be extremely common. If you work in a department where they call it in more than, say, 20% of their cases, then you have to have, you know, you have to be concerned about that. Because why this is so important? If I have extensive lymphovascular invasion, even without the new FIGO 2023, this patient will have pelvic lymph node, bilateral pelvic lymph node excision. So it's significant to the patient. But if you don't have extensive lymphovascular invasion, then this patient may have only, for example, she's a 1B, she may have only radiotherapy. So a huge difference in how we stratify the risk. So just 4 weeks after I made the diagnosis initially, I got the report from Cambridge, and this is how the report looked like, indicating there is a pathological mutation in BOLI. So that is very, very interesting. So what test do they use? They use the TSO 500 next generation sequencing, which is a large panel for DNA sequencing. The report takes on average 4 to 6 weeks to come. And it's a bit patchy because sometimes when there's a huge pressure on the hubs, it may actually be a little bit longer in the middle of the holidays, in the middle of Christmas, Easter, half terms. It does slow down a little bit, but on average, about 4 to 6 weeks it takes. So they don't only comment on poly, they also comment on all other genes relevant. So this is very, very important because these genes in the future may become targetable, and we may be able to look at them easily now because we already have the report. So this is very, very important. Um, and let's talk a little bit about poly. So they said they give you exactly the type of poly that is mutated, and also the tumor mutation burden that is has a very high. What do you mean by tumor mutation burden? That this tumor has a very, very high frequency of mutations, and this is exactly what we expect about the poly, to have a very high mutation, but those tumors behave in a really extremely benign fashion, and nobody really knows why. But my own, how I understand it, when the tumor is expressing a lot of mutations, it cannot hide from our immunity. So our immunity keep it under check, and it doesn't really have a chance to spread very quickly. That's my understanding about this. And so this was my final at the time. So let's back again to the time. 4 weeks from my diagnosis, I had the poly. 4 weeks later, the hysterectomy was done. And by the time when I received the hysterectomy, I already knew that the patient had pathological Boolean mutation. So by the time we discussed this patient in the MDT, we already know that she has a Boolean mutation. So in the MDT, we basically, when we know that, we were considering, shall we actually, does this patient need lymph node sampling in order to better stratify the risk as per the guidelines? But the moment we knew she has Boolean, she was reassured, and there was no neoadjuvant therapy and no further treatment for that patient. So extremely important to stratify the risk and prevent any further harm for the patient. So not all police are equal. So I really want you to understand that, because this is a new concept for the gynae world, and we are learning this as we go. There's a list of mutation, which was this one in our case, but there's a list of mutation that if you find it, this is pathologically poly. But there are also mutations in poly which are non-pathological, and we really need to be very careful about those, because those, if they say this is not one of the one associated with good prognosis, then the patient is not classified as poly. So very important to know that. Am I exceeding the time, or are we okay?
We've got a few more minutes.
Okay, a few minutes.
Yeah,
So
yeah.
I'm gonna touch on the new FIGO. So this is already Anna mentioned that about the new. This is the old FIGO that was very, very simple, and it's based on where the tumor is and how far it's actually in the myometrium. And this is the new FIGO 2023, which we decided last year. It was released in June 2023. We decided to wait for 1 year before we move to it. So we are now in March, so we kind of expecting maybe around July time, August time to move to this new. We will know more in 2 weeks when we are discussing it with the BAGB. But actually, it's far much more complicated than our current. But to summarize it, each tumor, depending, is it aggressive or non-aggressive? So anything that is not a FIGO grade 1, 2 endometrioid adenocarcinoma is considered aggressive, and it has its own FIGO. So for example, if you have an aggressive histology, and it's confined to the polyp or the endometrium, we put it as 1C. But if you have a B53 mutation, or you have aggressive morphology with any myometrial invasion, it become a 2C. So it's very, really different than what we actually so far experienced. And what is the big change is when you have a poly category, it, regardless of the myometrial invasion, regardless of the lymphovascular invasion, regardless if it's actually invading the cervix or not, it will go back to 1A. So I show you, so you can read that all by yourself. We're going to go into more details, like people in Derby, don't worry. You'll definitely see this presentation again. I'm going to do it again for our own MDT. But the poly mutation once you know that, that's how we write the final stage. Stage 1A, poly mutation, we put M, that it is a molecular classification. And that's the interesting category. If you have a B53 abnormality, then it automatically become a 2C regardless of what actually is the invasion level. So this is very, very important, and you're going to change the way how we stage those cases. So I'm hoping that I didn't like. I know that it's a lot to say in such a, and I talk a lot, but it's if you have any questions, please. I know that we are approaching um, the break. I don't want to take from your break, but I'm happy to take any questions. It's a lot to learn, and it's a very exciting time for pathologists and for all the gynae cancer.
Rand, thank you very much. We
you're
are
welcome.
always enthused by your talk. I think this is a very important talk because it's the biggest shift in classification and management of endometrial cancer. Now, I know you needed a lot more time for this talk, and what I will do afterwards is ask you to do a slightly longer talk and record it as an MP. You record it for me just as your talk, so that we can put it in a more detail on as a talk on the YouTube thing, because I know
I don't mind. I don't
we'll
mind.
do that, guys. Has anybody got any questions you want to ask, Rand? I'll ask something. In terms of the testing, because obviously one of the limitations we have is that it's all having to go to Cambridge, so that delays our management. When do you envisage this all being coming to our departments or each hospital?
I wish I can do it in-house, to be honest, because ideally, you really need to know the molecular at the time you discuss this patient in the MDT. Why? Because it will determine. So let's say if this tumor was a grade 3, and you know it is a poly mutated, you don't even need to do a sentinel lymph node. So this is extremely important to bring it in-house and try to do as much as possible. But the whole structure of the hub, and that the money is only going to the hub, and we don't have funding to be able to do the test in-house, putting so many obstacles in so many departments way. But it's I'm hoping that we will be able. So I like in Derby, it's really a long it's another talk. It's another experience for me, because I'm the lead in lung cancer. So at the moment, I got next generation sequencing in Derby, and I do all the molecular for lung cancer in 3 to 5 days, which is absolutely wonderful. If I'm going to send the same samples to Cambridge, it will take about 4 to 6 weeks, and patients don't have that sort of time. But the similar test can be extended. I can get another panel and do the poly in-house, but that needs funding, so it's another thing for the future. But so far, I think having a 4-week turnaround time, I think it's still very good.
Okay. So Sunitha, do you want to turn your camera on? I think we've got a couple of questions if you want to ask your questions.
Sorry, I don't have a camera in my
That's fine. Do you want to ask your question?
I have a question for the pathologist. Thank you very much for the lovely talk. If the patient has significant risk factors, and if the pathology finding is that of a necrotic polyp, necrotic endometrial polyp, does that raise all the red flag signs?
You mean like just a necrotic polyp without any cancer in it?
Without any report of a cancer and a background endometrial histology of endometrial hyperplasia and a necrotic polyp, and the patient has significant risk factors, raised BMI, diabetes, all that. These patients.
Because if the polyp is really necrotic, depending on what type of necrosis. Is that a tumor necrosis, or is just ischemic necrosis? So if it's an ischemic necrosis, means that the polyp, maybe there was torsion or some trauma to the polyp, or maybe prolapse through the cervix. It doesn't affect anything. But if I see something which I think it may be tumor in the background, and depending on what it looks on histology, I may actually ask for a correctings or a repeat sample to assess. I will consider that insufficient for assessment if it's necrotic. Because now we have to do so many more on our samples. We really need decent PPLs, and the majority of the work actually done on the biopsy rather than on the hysterectomy. So this is very important to know that. Yeah.
Thank you. Shaima, do you want to turn your camera on? And you can ask your question.
I just wanted to say thank you so much for such a good talk. I'm really impressed that you're sending Poli on all your endometrial cancers.
We do. After long discussion, they hated
amazing.
us.
I just wanted to ask, have you looked at how many of the Polis that were positive would have been eligible for testing, and how many you wouldn't have picked up if you were? Because I know there's the guidance that certain patients are allowed to get tested.
So, for example, this case, this patient, according to the BAGB guideline, it wouldn't have been sent because it's P53 wild type and microsatellite proficient, and it's not a grade 3. So these are the rules set by the BAGB as a guideline. But it would have been sent after you find it's a 1B. So that will really delay a lot the management. If I'm gonna wait till I call it a 1B, then send it to Cambridge, we will wait for another month to decide what to do for this patient. So this is why in Derby we decided, no, we're gonna send everything. And this is now the recommendation from FIGO. You cannot actually classify the tumors, and you have to send all. So we just now, actually, I'm just now finalizing an audit on the poly cases that we sent to Cambridge. So this will be a very interesting, like so far, I think we had about 8% of the cases we sent came back as poly. So we are exactly how it's expected. It's overall 5 to 8% of tumors are poly mutated, and 12% of the grade 3 category.
But certainly Cambridge won't be able to cope with the entire workload of all departments of all the cancers, because the numbers are huge.
The numbers are really huge. I think I've looked at how many cases we sent since May. We are approaching 100.
Yeah.
In about 9 months. So it's quite a lot of work, and it's a very labor intensive as well, because you have to think about the impact of this protocol on all different levels: the lab, the admin, getting that report back and getting it signed out, the interpretation, is it ready at the time of the MDT? There's so many factors playing in this, which actually makes this whole process very vulnerable when you outsource it. Yeah.
Thank you, Ran, for a fantastic and brilliant talk yet again. I know we've gone over time, guys, but I think that was very important talk, because that's the gist of the big management change in endometrial cancer. If we break now for maybe 5 minutes and reconvene at 10:40, guys. I know it's a shorter break than anticipated, but let's break for 5 minutes and we'll reconvene at 10:40 with our next speaker, who will be Neil Ryan. Okay, thanks very much.